Hello everyone and welcome to today's lecture on respiratory distress syndrome in neonates, one of the most common respiratory conditions affecting premature babies. In this video, we will cover what is respiratory distress syndrome, pathophysiology and the role of surfactant, and clinical features and diagnosis. Management strategies including surfactant therapy, complications, and how to prevent respiratory distress syndrome. Let's see the lecture. Respiratory distress syndrome, also known as hyaline membrane disease, is a condition seen primarily in premature infants due to surfactant deficiency. Surfactant is a substance produced by the lungs that reduces surface tension in the alveoli and prevents them from collapsing during expiration. Without enough surfactant, the alveoli collapse, making it difficult for the baby to breathe, which leads to respiratory distress. To understand respiratory distress syndrome, we need to talk about the role of surfactant and lung development. Surfactant production, and this is produced by type 2 alveolar cells and starts being synthesized around 24 to 28 weeks of gestation. By 34 to 36 weeks, there is usually enough surfactant to prevent RDS. In premature babies born before 34 weeks, there isn't enough surfactant, leading to alveolar collapse, impaired gas exchange, and hypoxemia. The hallmark of this syndrome is the formation of hyaline membranes, which consist of dead cells, proteins, and fibrin that line the alveoli, further impairing oxygen exchange. Several factors increase the risk of respiratory distress syndrome. Prematurity is the most important risk factor. Maternal diabetes that can delay surfactant production, and perinatal asphyxia reduces surfactant secretion. Caesarean delivery may not have the thoracic compression that helps clear fetal lung fluid. So, the male gender are more at risk due to delayed lung maturation. Let's now talk about the clinical presentation. Symptoms of respiratory distress syndrome usually begin within minutes to hours after birth. Tachypnea, the respiratory rate more than 60 breaths per minute. Grunting, that is to maintain alveolar pressure. Nasal flaring, intercostal and subcostal retractions, and the use of accessory muscles. Cyanosis, this is due to hypoxemia. On chest auscultation, breath sounds may be decreased and crackles might be heard. The diagnosis of respiratory distress syndrome is primarily clinical, supported by imaging and laboratory findings. Chest X-ray findings includes ground glass opacities due to atelectasis, air bronchograms, low lung volumes, blurring of the heart borders, blood gas analysis. This shows hypoxemia, hypercapnia, and respiratory acidosis. The antenatal history is important, like prematurity and lack of antenatal steroids are key clues to diagnose respiratory distress syndrome. Management of respiratory distress syndrome is aimed at improving oxygenation, supporting ventilation, administering surfactant replacement therapy. Let's break down these interventions. First, oxygen therapy. Nasal continuous positive airway pressure, that's NCPAP, helps keep the alveoli open and is the preferred initial mode for mild to moderate respiratory distress syndrome. Mechanical ventilation, this is used for severe cases where this CPAP fails. Second is the surfactant replacement therapy. This is cornerstone of RDS management. We administer oxygenous surfactant via an endotracheal tube. It is most effective when given within the first 2 hours after birth. And the antenatal corticosteroids, when this syndrome is suspected, antenatal steroids like betamethasone should be given to mothers at risk of preterm delivery between 24 to 30 weeks of gestation, and this enhances fetal lung maturity. For the supportive care, the child should be kept warm by thermal regulation, nutritional support. Premature babies may need IV fluids and total parenteral nutrition initially, and continuous monitoring of oxygen saturation, blood gases, and vital signs. Complications of respiratory distress syndrome. RDS can lead to several complications if not managed properly. Bronchopulmonary dysplasia, chronic lung disease due to prolonged mechanical ventilation and oxygen use. Pneumothorax, air leaks due to overdistension of alveoli. Intraventricular hemorrhage, this is common in preterm infants. Patent ductus arteriosus is due to impaired closure in preterm babies. Long-term complications may include developmental delays and neurocognitive issues. How, how to prevent respiratory distress syndrome? Actually, in every disease, prevention is key. And here is what we can do to reduce the risk of this syndrome. Antenatal corticosteroids are given to mothers at risk of preterm labor. Avoid premature deliveries when possible. Use of this pressure CPAP in the delivery room to prevent alveolar collapse immediately after birth. Antenatal magnesium sulfate. This reduces the risk of cerebral palsy in very preterm infants. In premature babies due to surfactant deficiency. Clinical signs include tachypnea, grunting, nasal flaring, and cyanosis. Diagnosis is based on clinical presentation and chest X-ray findings like ground glass opacities. Management includes oxygen therapy, CPAP, surfactant replacement, and antenatal steroids for prevention. Complications include bronchopulmonary dysplasia, pneumothorax, and interventricular hemorrhage that can lead to death of the neonates. Thank you for watching.